Welcome to the class of 2022 summer students and additional guests. So this lecture is, I guess, just sort of quite a top level overview of my perspective of cancer and radiotherapy. I first got into radiation therapy and medical physics as an undergraduate student, just like you are, and I knew very little about even what sort of the whole the whole field of medical physics or radiation therapy was at that time. Your research will unfortunately mostly be done not at hospitals or even in the lab setting or the in person. So hopefully, at least through the lecture series and through the team site, you'll be able to get a little bit of the support or some of that experience. And if we can, we'll try and get you at least to see some of the devices and areas where patients are treated, because I think that's probably something we'll keep coming back to, at least in this lecture and the other lectures. It's about that even though we're using mathematics, physics, engineering, we're using all of these skills and tools to help improve how we can image and target disease and typically cancer with radiation therapy beams. So with that, I'll just jump into this as Yusuf and Julia said, please interrupt at any time, and we can. Otherwise, I'll just keep talking. I will respect the end time. So we've got quite a number of lectures of different lectures of different sort of aspects of radiation therapy and imaging over the course of the next 6 weeks, maybe 7 weeks. And so my lecture today is an introduction overall to radiation oncology from my perspective, and also to talk about some of the problems or the limitations of today's technology that you're developing that can have a real world impact on the lives of future cancer patients. So there's, and I think one of the things we hope you get out of the summer experience is just really understanding what medical research is about, but also a real sense of satisfaction that you can have in contributing to the field of medicine via science. It's an incredibly rewarding area to be working in. So my first experience, as mentioned, was as an undergraduate student this was in Hamilton, New Zealand, and I walked into a room which looked very, very similar to what we have here. There wasn't a patient in the room at the time, but it was, you sort of walk through this maze. There's 6 feet, 1.5 meter concrete walls to shield the high energy radiation. And in this room, every day, 30 or so cancer patients will come in, be positioned by the staff, and then lie down on this machine and be treated with radiation therapy. So it was just a really moving experience for me to be in that environment for the first time, and I think sort of very sobering and focusing on the patient, and this isn't just an academic exercise, but at the end of the day, we're hoping to improve the quality of life of cancer patients. So this is a linear accelerator that I will talk a little bit about, and Brendan Whelan this time next week, we'll talk a lot more about. So hopefully there's a plug, and there'll be some that's a lecture not to be missed. So cancer is the leading health burden in Australia. Cancer and cardiac disease tend to be the 2 biggest global health burdens, and that's by both health and economic economic metrics, the cost of healthcare and the cost of patients. It's around, interestingly, the economic impact, 1.5% of global growth, the global gross domestic products, about nearly $1 trillion. So 1.5 cents of every dollar spent is spent on cancer. And I think that's interesting. About 8%, between about 8 and 16% of gross domestic product of countries is typically spent on healthcare. And so cancer is taking up a little, just under a quarter of that. So it's quite amazing sort of when we think of it, that 1.5 cents in every dollar is spent. So radiation therapy is, it's very cost effective and least invasive cancer treatment. And there's radiotherapy contributes to 40% of cancer cures, and it's quite cheap, cost effective when compared to surgery and chemotherapy. Even though there are different indications, these are 3 of the 4 mainstays of treatment. In Australia, about 2/5 of the patients receive radiation therapy, and about half of patients are indicated for it. So I'll touch on this a little bit more. And a key thing for those involved in research and a justification for why research in this area is important is that improvements in technology have and will continue to improve cancer outcomes. So it's not just improving technology for technology's sake, but it's actually that better technology results in more accurate treatment, results in improved quality of life for patients. As far as magnitude, so the most common cancer in women is breast cancer, and so the lifetime risk is about 1 in 8 women will get breast cancer, and in men it's prostate cancer, and about 1 in 9 will get prostate cancer at some time in their life. So these are sort of very sobering statistics. So I guess a question, how is cancer diagnosed? And I think a number of people have had, almost everyone has been touched by the impact of cancer in some way. Does anyone want to share about how cancer can get diagnosed?
I'll jump in because Paul, I guess aimed at some students, but there are 1,000,001 ways. And so I think other people might want to jump in too, but usually some sort of functional change, whether it's just feeling sick or whatever else. Some sort of symptom. I mean, is the trigger for, but
yeah. Anyone else?
Usually, does it get imaged like a CT scan or like something like that?
Yeah. So yes, and there's we do have screening examples, and wonderful screening tools in Australia, such as Breast Screen New South Wales and mammograms. So just sort of routine cancer screening procedures. There's also for bowel cancer, and there's recommendations around prostate cancer as well. Thank you, Athena, for the tissue sampling. So for example, if you've got a suspected skin cancer that is visible, then you can take a biopsy. Sometimes for head and neck cancer, it's something that dentists will screen for now. Often, as David said, if you're unwell, so you may have a cough that you get given antibiotics for, and it doesn't resolve, and can end up being, for example, for lung cancer. So these are rare, but there's just many different ways of how cancer is diagnosed, and that's one of the areas that we don't really look at that sort of that early diagnosis stage within the sort of research portfolio of we're doing, but it's obviously the first sort of step of the cancer journey, and we'll talk a bit more about that as we go on. So there's a whole lot mentioned. There's many different ways of how cancers are of how cancers are diagnosed, and of course there's about 100 different cancers, and we sort of, rather than lumping them into one, we do lump them into one group because there are some common elements and hallmarks of cancer, but they are very different. They have very different aggressiveness, and when they're detected overall, and the impact. So overall, with cancers, about two-thirds of people with cancer will have a five-year survival, and this is in some ways a sobering slide, but also a good news slide, that in 30 years, well, nearly 50 years ago now, about half of people lived for 5 years with cancer, and 15 years ago, it's around two-thirds of people are surviving 5 years with cancer. So improvements across all of the cancer spectrum, from prevention, from detection through to treatment to symptom management, are improving. Some of the cases the types of cancer we do quite well on as far as survival: prostate cancer, the most common cancer in males, most common cancer in females; breast cancer, nearly 90% of women are surviving 5 years after cancer. So for the most common, there's also some cancers that are within the research portfolio that we are working on, are these lung and liver and pancreas cancers, which have very, very poor 5-year survival as well, and also brain cancer. So even though there's some cancers that we have a lot of success, so for example, for prostate cancer, we want to treat patients, though their survival is high, we can help these patients have a good quality of life by reducing side effects of treatment. At the other end, where there's lower survival, what we want to be able to do is to improve the treatment of be able to provide tools to improve the treatment of the disease itself, so that the more patients are surviving a longer period of time. Again, and we also want to have a good quality of life as well. The main point that for all of these cancers, we are getting better at treating and improving survival of these cancers. So how often is radiation therapy used for cancer patients? You'll hear this quite a lot, that about half of cancer patients are indicated for radiation therapy. So the two most common are the most common in women. Breast cancer patients, almost every patient gets radiation therapy, and over half of the prostate cancer patients get radiation therapy. And in Australia, melanoma is quite a common cancer as well, and also the most lung cancer is the cancer that causes a lot more deaths than any other cancer, and that's radiotherapy is used for nearly 80% of treating lung cancer patients. So there is a variety of when radiation therapy is indicated based on the cancer type, and also based on the stage of the disease and the individual person, any potential comorbidities as well. And overall, so some work done at Liverpool Hospital in Western Sydney was looking at how much does radiation therapy improve local control and survival across the different cancers. And the findings were 23% there's a 23% 5-year local control benefit for all patients, and a 6% increase of 5-year survival of patients receiving radiation therapy compared to those who don't. And very cost effective as well, for $13,000 per year saved. And for putting that in context, normally it's around sort of $50,000 to $100,000, which would really, from what health economists use as a point of whether something is beneficial or not. So what are we doing in radiation therapy? We're giving a dose of radiation or radiation energy to a tumor. And X-ray doesn't know the difference between a healthy cell and a tumor cell. So it's really the targeting and the focus of the radiation beams and the additive effect of multiple beams that are going to help us improve the radiation dose that we're giving to the tumor compared to that normal tissue. You can't avoid normal tissue with radiation. So what we're trying to do is, we know that there's a dose response of the tumor. So on the x-axis, we've got the radiation dose, and this is something that we've got quite accurate control over. We can give as much radiation dose as we want. There's essentially no limit. And there's the response or the toxicity rate. So of course, the more radiation dose that we give to the tumor, then the higher control rate will be. As we get more radiation dose to the tumor, we necessarily give more dose to the normal tissues as well. And this is really where the fine balance comes in. So we've got an effective treatment, but a toxic treatment. The goal of a lot of the research is trying to move this, trying to make the treatments less toxic. It's essentially moving the dose required to make I guess it's trying to separate the curves so that we've got a larger difference between the dose required to cure or to achieve treatment effect to the dose that will cause harm. So for a lot of patients, there is this balance that the treatment team are managing when it comes to radiation therapy as to what dose to give, because there's often there can be side effects. So jumping into some of the where cancer is on a global scale, and we're extremely fortunate in Sydney to have access to many outstanding radiation therapy centres, and with excellent, well-educated teams and staff. That's very different for most of the low and middle income countries. And interestingly, that in developed countries, the increase in cancer cases is growing very much with the population. In less developed countries, where the life expectancy is increasing because of improved treatment and control of non-communicable of communicable diseases, then people are living longer. And so the increase in cancer cases in less developed countries is increasing at a more rapid rate. And so obviously the two sum up to get the growing numbers in the world. So the more rapid increase in the less developed countries is a really strong driver for radiation therapy being quite a cost-effective treatment for cancer. though we would still like to make it more cost effective and be able to be deployed more broadly as well. So I've talked about the 48%. In developed countries, radiation therapy is used between 20 and 55%, but in developing countries, the rate is I think about 30 countries in the world now don't have any access to radiation therapy, and to about 25%. There's a real global shortage of cancer radiotherapy systems. So this is a map of the world, as I'm sure you know. It's color-coded with the amount of the number of people served by one radiotherapy unit. So for the green, for example, in Australia, we've got at least one radiotherapy unit for every 500,000 people, 500,000 population, and you can almost track the need and the correlation between radiation therapy units with the gross domestic product of countries. Red is where there is no radiotherapy units, and so there's that they either don't get cancer treatment with radiation therapy or need to travel to a different country. So what does this mean? And one of for HIV, there was a massive global investment with HIV, and making that HIV and AIDS go from really to be a chronic disease, at least for those with access to retroviral drugs and medicine. And there was really a concentrated effort to make that happen. And there have been efforts within radiation therapy to really try and bring governments together and have a much larger investment in cancer treatment as a whole, but particularly in radiation therapy, to help make this take the disease to really be a lot more sort of chronic than it currently is. So there is a shortfall of radiation therapy machines, and so what we really are looking at, part of the motivation for some of the work that you'll be doing is how can we make these existing units be more cost effective and work better. Okay, so switching gears a little bit to the cancer radiation therapy process. So earlier we talked about the diagnosis of cancer. Once that happens, then when it's been confirmed, typically by biopsy, then the patient would be seen ideally in a multidisciplinary clinic where there are people with expertise in surgery, medical oncology or chemotherapy and radiation therapy. So that there'd be a consultation, and if the person is referred to radiotherapy, then they would come to the imaging, and where we trying to look inside where the cancer is inside the patient. And it's quite a challenge where we're treating something that is invisible from the outside. You can't see the cancer from the outside, and we're using an invisible beam to treat it, and that the cancer that we can't see, this invisible target, is also changing with time as well. So there's quite a challenge that we have, and so there's a number of tools that we use to help us visualize or help us at least manage this problem. So we image the patients, and we take a treatment plan. This is a CT scan taken through the middle of a chest of a lung cancer patient, and overlaid in the middle here we have the cancer. Here we've got two beams, one coming from the right, and one coming from the bottom, and where they overlap in the center, where they overlap, the radiation is summed, and so the dose to the cancer is higher. So this is where we're sort of simulating what is going to happen in the treatment, and then the patient goes to the treatment unit, where they are treated typically in 1 to 30 individual sessions. And finally, there's follow-up as to the patient, how are they doing, if they have side effects, are there things that can be done to help manage the side effects? Has the cancer recurred? Do they need further treatment? And throughout each of these stages, underpinning all of this work is quality assurance. And Jonathan Hindmarsh who's a clinical medical physicist, will be talking more about the cancer journey in a later lecture. So just to touch on a linear accelerator, which is the workhorse what most people are treated with around the world. Here's an example of one. So in the treatment head is where the radiation is produced, and so we start by just with an electron gun. So we take a cathode with a focusing electrode and an anode. So we make we heat up a cathode to 1,000 or so degrees. Apply an electric field across electric field, for example, of tens of kilovolts across between the anode and the cathode, and so that will the electrons will then be accelerated across and through a gap, in this case creating an electron beam. The electron beam is then accelerated through an accelerating structure as shown. Brendan will give a lot more detail of how this works. But so we have electrons coming in from the left and are accelerated to about 0.999 times of the speed of light. You can see here it's color-coded with energy. And what's not shown here is that these electrons hit a tungsten target, and from the tungsten target, the electrons become X-rays. So it's quite a complex and expensive process to create the X-rays, but where there's no essentially disposable parts. So these machines can cost around $3 to $4 million, but because there's no essentially consumables, that these are used again and again, and can treat thousands of patients in their lifetime. So overall, it can be quite cost effective. So we need something. We've got a broad beam of X-rays, and we need something to shape that. And so what is typically used in most treatments are multi-leaf collimators, and these are tungsten leaves of approximately 8 centimeters thick, that will where the tungsten is not blocking the radiation, the X-ray beams will obviously pass through, and where there is the tungsten blocks, it absorbs about 98.5% of the radiation. And we can also measure the radiation. So most of the radiation will pass through, most of the megavoltage radiation will pass through the patient. So we can image, there's an imager that can be deployed beneath the patient. And from that we can see we can see both the edges of the radiation beam. We can also see some of the anatomy through the of the patient that is being treated, that can help us with our quality assurance and targeting. Another tool that we have on our linear accelerators are X-ray, an X-ray source, and an X-ray panel. And from the, we can get images such as this. And here we can see this is a femoral head, and this is the images of a prostate patient that are required during treatment. So we've got tools that can help us to image the patient while we're treating them, to help us find this invisible target and treat it with an invisible beam. We can also keep both, if we keep both of these, the kilovoltage imaging during treatment and the megavoltage and the portal imager during treatment, we can get dual views of the two-angle views of the patient at the time of treatment. And some of you may be working on projects related to this, to these technologies. There's a lot of radiation oncology systems available that have been developed, and they've got different sort of guidance, different ways. That the main difference is how they're detecting the tumor position during treatment. What most centers have in Australia is similar to the one I've been describing, where we have an X-ray imaging system, a megavoltage imaging system, and a treatment beam, and this rotates around, a so-called gantry rotates around the patient, where it can deliver multiple beams. And in Australia, I think there's 200 of these linear accelerators, and only three of these are sort of the more dedicated systems. So most people have these C-arm or gantry mounted linear accelerators. So if you're working on technology, will it have an impact? And it's good to see that how trends in radiation therapy and that the uptake of technology. These are getting a little bit old, but what it shows is that overall, if we're looking at the time in years and the percentage of respondents, these are from surveys. So this is imaging and radiation therapy in addition to a CT scan. And so what we're seeing with time is that there's just a general increase in imaging being used to help us find where is that cancer target before we treat the patient, to help us with our delineation. So we're pretty much seeing more than half of people adopt new technology in about a decade. So that was imaging before we treat the patient. If we're looking at imaging at the time, imaging the patient every day during treatment, then we're seeing similarly, there's a number of technologies that are being increasingly being used. And so we're seeing, again, over half of centers are adopting additional technology in about a decade. And similarly, with the growth of STEREOTACTIC body radiotherapy, in which there's increased accuracy requirements in treating patients and using fewer treatments with much higher treatment doses, and again, there's quite a large change over a decade. So technology is changing. I think in medicine is quite a regulated industry, which is good for safety, but it also means that some of the changes in technology probably take longer than we would hope to get to patients. So why do we expect improvements in technology to result in better outcomes? And there have been a study, this is from a 2010 series of research papers looking at a number of different organs of the body and how they respond to radiation. And if we just take a look at one of those, so this is lung for the response of the toxicity of treatment for lung cancer. So the more on the x-axis, we've got essentially the average radiation dose that we're giving to the lung. And on the y-axis is the probability of pneumonitis, which is inflammation, essentially inflammation of the lungs, which is a side effect of radiation therapy that we want to avoid. So it's very clear that as we give more radiation dose to the patient, that the likelihood of toxicities increases as well. And it's we can model how much we will benefit from reducing the radiation dose if we can reduce the radiation dose to the lungs by better targeting, we can estimate how much benefit that will have for an individual patient. And just the magnitude of patients being treated, for example, in the US, about 100,000 lung cancer patients will be treated every year. So even a small improvement to the technology can result in a large number of quality of life improvements. So there are so many things going on during radiation therapy where the patients are live, dynamic, we're all alive, and the many different systems within our body are many different, the respiratory system, the cardiac system, all of these are digestive system, even it's very hard even just to stay still if you're asked to. So there's anatomic changes that are occurring. There's also physiologic changes both in your body and also with the tumor. So we've got this very dynamic system of both the cancer and the patient that we're trying to optimally treat. And these temporal changes or changes with time are probably something we're quite at the early stages as far as being able to manage well these changes. So there's a lot of opportunity to improve here. The main point of this slide is just that we've got a very dynamic human body. And so some of the challenges of radiation therapy, and so what human systems cause tumors to move, and I might just I'll talk briefly about that, but probably some of the things that we're mostly focusing on are breathing motion, because it's one of the largest, and cardiac motion is also because the heart is one of the most I guess radiosensitive structures in the body as well. So with breathing, why is breathing a problem? Here's some data from a cancer patient measuring the tumor as the tumor is moving with time while a patient is being treated. So we've got the three different motions. So essentially up, down in the patient, front and back, and left, right. So what we're seeing is that while a patient is being treated, a tumor is moving in 3 dimensions. It's moving up to several centimeters, and the tumor can be drifting with time, like the position within the body. The position with each breath is changing. So this is quite a challenging situation to be from a targeting perspective. So we've sort of got two tasks here: finding where the target is and how to hit that, and how best to hit the target. So that was for a lung cancer case. Just similarly for a liver cancer case, this was treated with 5 different, a patient with liver cancer treated with 5 different radiation beams. So there was they were setting the patient up where they thought that I guess had assumed that the patient would remain at the time of treatment. There was the tumor had drifted just from the patient's possibly relaxing, and so there's a difference between where the average position of the target is, and also that at any instantaneous time we've got this target motion. I might just skip that. Breathing motion is periodic. There's other organs in the body are treated with radiation therapy, and one of the most the most common cancer in men is prostate cancer. And so the prostate cancer, there's still motion, though it moves in quite a different way with different characteristics from for example, for lung and liver cancer. A lot of the time there's very little motion, though there can be sort of slow and continuous drifts, and there can be occasional large shifts. This is mostly due to either twitching, either the patient moving, or for bladder filling or rectal gas. So these sort of changes can happen, and that they're happening while the patient is being treated, which is the critical thing from a radiation therapy perspective. And I might just possibly a bit detailed in the interest of time. So I think one of the goals of the research program, what we're seeing during treatment now is typically that we're not imaging while the patient is being treated, and what we are hoping to achieve. The movies aren't working, but just being able to have it be visualizing the cancer at the time of treatment. And so several of you are working on projects in this space. There are different technologies that have and are being used to monitor where the patient, where the tumor is within the patient. And interestingly, it's a lot of the electromagnetic spectrum, different parts of the electromagnetic spectrum are being used. So we have the X-rays, both megavoltage and kilovoltage. We've got the electromagnetics. This is radio frequency, using radio frequency localization. We've got, you can use radioisotopes. We can use the visible spectrum to image the surface of patients, and we can use combinations of the various technologies as well. And there's also, for volumetric imaging, there is ultrasound and MRI. And MRI is one of the David Waddington will give a talk about MRI in radiotherapy, I think, as the last, the final lecture course, the final lecture in the course. So a program that we have taken from concept to clinical treatments is kilovoltage interfraction monitoring. So that is using the kilovolt, the detector, the X-ray imaging system of a linear accelerator, imaging the patient using 2D, detecting where the markers are that are implanted in the prostate, and then using mathematical operation to go from 2D to 3D. Then this will tell us where the tumor is in space at the time of treatment and allow us to move the radiation beam. And I'll jump through. There's also a number of different ways I've talked about. If there is motion of the tumor during treatment, then ideally we want tools that can help, that will have the radiation beam follow this moving target. And there have been robotic approaches to this. There have been using a gimbaled approach, and this is a picture of a much younger me in Japan. The most common device used for beam shaping is the multi-leaf collimator. So that is a tool that we have put a lot of time and effort into the research, development, and clinical application. So using each of these leaves is governed by is driven by a stepper motor, so we can shape the beam individually with time. And also that the couch that the patient lies on hasn't been used clinically, but could be used for this to assist with the targeting. And I think we're just so for the multi-leaf collimator tracking. So we're using how do we shape the beam in real time. So we need to know where the target is, and just showing you this is quite a nice demonstration of sort of physics and mathematics in action. So we need to know where the target is. If there's a periodic component to the signal, then we would like to estimate where that tumor will be in the time that the system can respond, the time the system takes to respond to that motion. So there's a time series analysis process that goes on. We then want to determine where the optimal position of the radiation beam should be. So we run an optimization process in real time. So there's a mathematical formalism that is being continually being called and executed in order to optimize treatment. And then we have the engineering process of taking the mathematical optimal into real world instructions to send the leaf positions to control the beam of the patient, of the radiation beam, while the patient, adjusting the radiation beam while the patient is being treated. And so I think let me just briefly summarize. So one of the programs that we have is integrating MRI with a linear accelerator, and that this has been an ongoing program at Liverpool Hospital, where we're using MRI, one of arguably the best soft tissue imaging modality, and integrating that with a linear accelerator, so we can combine imaging and targeting in a single device. So the I guess, you know, the rationale is that we can have very high contrast and a fairly high confidence about where the target is with time. So how do we, linking them again, if we're sort of looking from a physics, biomedical engineering perspective, then the tasks, we want to see the target. How do we do this? We need the rapid MR imaging. We need image registration tools because we've got a volumetric problem. We've got a time delay between seeing the target and hitting the target. So we need some time series analysis, and then plan adaptation. And so we've got some real-time mathematical optimization going on, and to enable us to adapt radiation, the radiation beam in real time to the patient. There are a few more slides, but I might just, as far as the steps, just jump to the summary. So all of the students and a lot of the Image X researchers are involved in improving radiation therapy, and there's really strong clinical drivers. So as mentioned earlier, we're not doing technology development for technology's sake, but that there are strong links between better technology and better outcomes. You are involved with developing tomorrow's clinical technology, and it's something that is incredibly rewarding and satisfying. And I really hope that over that you get a really small but hopefully lifelong interest in the taste for that. And yeah, I think that hopefully things can work out, and we'll try and manage these very different situation in 2022, and that you have a successful summer project. With that, I will jump off. And are there any sort of broad questions either about cancer and radiotherapy, or the talk, or the summer, project?
Well, I have a question for you, Paul. I'm wondering, so there's been several revolutions in radiotherapy. I think the previous one could have been the intensity modulation therapy, and how that's now become pretty much the most common treatment. Slowly, I think we can see that adaptive treatments are moving from research to the clinic, although it's still a slow pickup. What do you think is going to be the next one after that? The next revolution in radiotherapy?
Right. Yeah. So we're seeing a lot of improvement in being able to account for changes in anatomy. And that's like still a lot of what we're doing we're doing with this, but we're also seeing, but I think that changes to functional, incorporating functional changes, both so changes within changes of the healthy organs. So, for example, that we currently treat the lungs as just sort of, the lungs, though we know there's a lot of structure and change that we can, within the lungs, as far as function goes, and all of the other organs. And then also, so being a lot more sort of detailed about function, and then also the tumor physiology as well, that so the sort of hypoxia, or areas of the tumor that get very low oxygen, are known to be much more harder to sort of less sensitive to radiation, much more likely to so they're harder to cure, and typically more sort of aggressive and likely to metastasize. So there's we sort of, if there were ways that we could image these, physiologically avid or even less avid areas of the target, as where then that would really open up avenues for improving that sort of therapeutic ratio. And so there's a lot of new tools and new things to be developed, not just sort of improving on what we're doing now, but rethinking whole new ways.
Thank you. There's a question in the chat asking, what do you think is the reason for decrease in survival for uterus cancer?
Yeah, that's a really good question, and probably what I would imagine would be that it was possibly being not being well diagnosed. It's quite a rare, uterine cancer is quite rare, and so I don't think it would be that treatments had become worse, but because that there were possibly being that it was not being diagnosed. This is sort of comparing 1970 to 2000, 1970 to 77 to 2007 to 2013. So there were possibly just wasn't being that well picked up or characterized. But that is quite interesting on that, a bit of a change in that on that plot. But it's also not quite a rare cancer.
Yeah, I also wonder if perhaps some of it has to do with the reduction in HPV-related uterus cancer. Because I know, there might be two types of cancer. One of them is HPV that is more related, that is more curable, and non-HPV is harder to treat.
Great. And maybe just in the interest of time, we will close there. Thank you, everyone. Thanks, Yusuf and Julia. And I think we'll see each other again soon.